So we have 50% response rate. So please vote. As I've been saying, the answer will come anonymously. So okay, thank you. So I will end it here and share you the results. Can you see the results, Doctor?
Yes. Yes. Presentation only, so later. So can I proceed?
Yes, yes, Doctor, you can.
Okay. So welcome to the weekly update lecture. Today we will be discussing about an ancient drug that is repurposed for cardiovascular care and treatment. So this is my outline of presentation, and I will directly proceed to the presentation. I love history, and in history, we are today discussing about colchicine, as you have seen in the pre-test as well. This colchicine is derived from a plant called Colchicine autumnale. I have tried the translation in Amharic. It translates as bukbuka. It's available in our country, but I couldn't able to, as a farmer, I couldn't able to identify which plant it is. But it is used to be a treatment for years long in Greek as a laxative with its side effect. And later, since 1500 BC, as clearly written in Irbis papyrus, Egyptians used it for the treatment of gouty arthritis. And later, Hippocrates also practiced this molecule for the management of gouty arthritis, as you see here. And later, the molecular structure, the chemistry was analyzed later. So in history, it is one of the oldest remedies still in use. It's derived from the bulb-like corms of the Colchicine autumnale plant, also known as Ottoman crocus. In history, it was used by the Egyptians as a management for pain. And the name Colchicine is derived from the ancient and legendary kingdom of Colchis, from where Jason recovered the golden fleece and where Colchicine autumnale plants were widely spread. And this plant is a house plant or a garden plant. Sometimes it also available in meadow areas where livestock productivity is in place, and it's
Dr. Atisu, please.
to the Great Britain and Ireland, but it is a widespread in Europe from Portugal to Ukraine in the Colchis kingdom. You might seen this film, Jason and the Golden Fleeces, this a golden wooled ram was in Greek mythology believed as a symbol of authority and kingship. And this mythology was practiced in Colchis Kingdom, surrounding countries around the Black Sea, and the name colchicine was derived from that, and this plant is widely grown there. Regarding use of colchicine so far, most common, it is used for gout and pseudo gout, as well as for familial Mediterranean fever that helped the medical community for a wider and prolonged administration. And it has also novel applications in dermatology and in autoimmunity. It's used in the management of Behçet's disease, chronic urticaria, in Henoch-Schönlein purpura, scleroderma, relapsing polychondritis, recurrent aphthous stomatitis. All these are applications of colchicine for the management of dermatologic conditions. And today we will be focusing on cardiovascular applicability of this molecule. Regarding pharmacology, colchicine its uptake occurs in the ileum and jejunum, and it is metabolized by the liver. Around 60 to 80% of the drug is metabolized by the liver, and the rest is by the kidney. And there is also a placental cross the placenta, and it through the breast milk as well. When it is swallowed and absorbed in the body, it becomes highly concentrated in leukocytes, especially in neutrophils, due to their limited expression of P-glycoprotein. It's also have an elimination half-life of 27 to 31 hours. And the mechanism of action is so far partially understood. A lot of work was conducted by Massimo Imazio from Italy and Mark Nidarov from Australia. They did an extensive review regarding colchicine and its applicability in cardiology, and they tried to see the mechanism of action. It's partially understood, but many important mechanisms are understood. And this colchicine interferes with microtubule function that results in inhibition of neutrophil function, interference with expression of selectins and neutrophil platelet aggregation, and inhibition of inflammasome. And the focus and the applicability in cardiology is regarding its anti-inflammatory effect. So this anti-inflammatory function is because of a combination of actions. One, by inhibition of granulocytes. Second, by interference with qualitative and quantitative expression of selectins on endothelial and inflammatory cells and platelet aggregation stimulated by inflammation. The other is non-specific inhibition of inflammasome by interference with the assembly of its components with inflammation stimulation. So colchicine used in cardiology because of its anti-inflammatory action is well established and recommended by guidelines, and it is wider use in pericarditis. We will see details. And it is used in acute and chronic coronary syndrome. There are emerging indications and ample data. And there is also still ongoing and well defined as well as to be defined functions to be used in the prevention of post-operative atrial fibrillation and atrial fibrillation after pulmonary vein ablation, as well as in the treatment of heart failure. We will see this all in details. The first one is colchicine for the treatment of acute and recurrent pericarditis. So the use of colchicine for the treatment of pericarditis was first proposed in 1987, and later the rationale for its use in this setting stems from the observations that colchicine was safe and highly effective in preventing acute flares of polysaccharitis, including pericarditis in patients with familial Mediterranean fever. There are several studies that we will see later. Overall, in patients with pericarditis, colchicine added on top of standard anti-inflammatory therapy halved the risk of recurrence, and it also halved the incidence of post-pericardiotomy syndrome after cardiac surgery. After cardiac surgery, because the pericardium is touched, inflamed, and the risk of post-pericardiotomy syndrome, including massive pericardial effusion, is common. That can be halved by administration of colchicine over a standard therapy. So studies on pericarditis, these are a list of studies, but the most common study is conducted by Massimo Imazio from Italy. Colchicine, in addition to conventional therapy for acute pericarditis, results of the colchicine for acute pericarditis, the COPE trial in 2015, and subsequent trials demonstrated that there is a significant reduction in recurrence of pericarditis, re-emergence of pericarditis, and even in patients having recurrent pericarditis, there are positive results, and these are a list of studies. I will not go into in depth of all these studies, but I will display the meta-analysis which is conducted by Imazio and Mark Nidarov, which is published last February 2021 at the European Heart Journal. And it clearly demonstrated that risk of pericarditis in patients treated with or without colchicine in different settings, its effect in on acute recurrent pericarditis and prevention of post-pericarditis syndrome. As you see this, the frozen frost curve, it is favors experimental therapy, colchicine, in all of the studies. And it is incorporated in the guidelines, the European Society of Cardiology guideline, which is published in 2015 for the management of pericardial diseases, incorporate colchicine as a class 1 and level of evidence A recommendation to be used for the treatment of acute pericarditis for a duration of 3 months. For those patients more than 70 kg should be less than 70 kg should be used 0.5 milligram once, and for those above the 70 kilogram should be used on BID basis on top of standard therapy, aspirin and non-steroidal anti-inflammatory drug for a better response in preventing recurrence and resolution as well. Even in patients with recurrent pericarditis, colchicine at a recommended dose should be used for 6 months for patients having recurrent pericarditis. But other agents, aspirin and NSAID, are a mainstay of treatment, but should be used until complete symptom resolution. But colchicine should be given for 6 months. But for those patients who are intolerant to colchicine because of its GI side effect, can be reduced into, can be given less or even can be longer for those having a minimal response. In patients with pericardial effusion, still the first recommendation is it is recommended to target the therapy of pericardial effusion at its etiology. But aspirin, NSAIDs, colchicine, and treatment of pericarditis is recommended when pericardial effusion is associated with systemic inflammation. So colchicine in coronary artery disease. This is emerging, there is emerging data. The use, it is used in pericardial disease is already settled and incorporated in the guidelines as so far as level 1, level of evidence A and class of recommendation 1. But is used in chronic coronary artery disease is emerging in reducing rate of ischemic cardiovascular events. So investigations on the use of colchicine for secondary prevention in patients with chronic coronary syndrome stemmed from its action in inflammation, its effect on anti-inflammatory activity, and the observation that the long-term use of colchicine was safe and effective for secondary prevention of acute inflammatory flares in patients with gout and familiar Mediterranean fever, has a good clue that colchicine can be used for a prolonged period of time as a preventive therapy, as a secondary prevention. The more emphasis was given after the publication of a data from Cantos, canakinumab in the management or in the secondary prevention, which confirms that interleukin-1B plays a central role in atherosclerotic process. This Cantos trial from Harvard Medical School great physicians were engaged in this study. Like Eugen Branwald is one of the authors of this publication. Canakinumab anti-inflammatory thrombosis outcome study, which was published in 2017, revealed that the idea was incepted that from CRP to interleukin 6 to interleukin 1, moving upstream to identify novel targets for atero prevention. As you see, cholesterol crystals, neutrophil, extracellular traps, hypoxia, all combined and induced inflammatory molecules of interleukin 1 and interleukin 6 that has an effect in vascular inflammation, increased vascular inflammation, increased endothelial dysfunction, and hastens a progression of atherosclerosis. So atherosclerosis is an inflammatory disease, and it's clearly understood that this interleukin 6 release has induced the liver to release CRP, which is an inflammatory marker in the blood, and those patients having a high CRP, it's known that they are at risk of fasten atherosclerosis process, as proven by clinical trials like Jupiter. And this inhibition of interleukin 1 and interleukin 6 by using canakinumab, which is administered every 3 months as a subcutaneous administration, significantly decreased major atherosclerotic cardiovascular events in both primary endpoints as well as secondary endpoints. And this CANTOS trial was published in the New England Journal of Medicine, and it was a big applause to the medical community. And this inflammation, as blocking inflammation, has an effect on the progression of atherosclerosis in the regression of major atherosclerotic cardiovascular events. Colchicine in atherosclerosis pathogenesis was also studied then after. Its mechanism by inhibition tubulin depolymerization that on neutrophils, macrophages, and endothelial cells results in a reduction in interleukin 1, a reduction in tumor necrotic alpha, and a reduction in E-selectin that ultimately reduce inflammation, reduce oxidative stress, and reduce endothelial dysfunction. That has a clinical effect in plaque stability, plaque progression, and plaque rupture will be decreased. And this postulation was widely studied by secondary prevention studies of colchicine by Mark Nodarov and his team first in 2017 as a prospective study that was studied by giving colchicine 0.5 milligram, a low dose, twice daily for 1 month, plus aspirin with a standard therapy. And he demonstrated that there is a significant reduction in high sensitivity C-reactive protein that ultimately studied by a small number of patients involving 532 patients in the low DUCO trial, which was published in 2013 as the Journal of the American College of Cardiology, demonstrated that administering low-dose colchicine showed a reduction of cardiovascular events, acute coronary syndrome, out of hospital cardiac arrest. Can you mute? Can you mute others?
Yes, doctor. I am muting, but some of Dr. Lencho, please mute your mic, and Dr. Pasika and Dr. Hannibal now.
Yeah, please, or either you have to block them.
Sorry.
It is disturbing. So can I proceed now?
Dr. Pasika, please mute your mic. Please proceed, doctor. Sorry.
Okay. So the secondary prevention trials, with a larger patient size involving 5,522 patients, the LUDUCO 2 trial, which was also presented at our journal club, colchicine with using 0.5 milligram daily over a standard therapy, which was a double-blind randomized controlled trial, demonstrated a significant reduction of cardiovascular death, myocardial infarction, ischemic stroke, ischemia-driven coronary revascularization with a 31% reduction in terms of primary and secondary composite in cardiovascular outcomes, as demonstrated by the low-do CO2 trial, which was done by a team led by Nidarov, and demonstrated that this molecule is very helpful in chronic coronary syndrome. The low-do CO2 trial, which was published in New England Journal of Medicine last August 2020, in conjunction with the European Society of Cardiology 2020, the digital experience, and received a big applause in the medical community by demonstrating that the use of colchicine, in addition to the standard therapy as compared to placebo, has a 31% reduction in cardiovascular outcomes in a patient population of more than 5,000 patients involved in this study. And key secondary endpoints in terms of cardiovascular death, myocardial infarction, or ischemic stroke was also significantly reduced as compared to the placebo. What about in colchicine for prevention of acute coronary syndromes? It was also studied. These are small studies that showed reduction in inflammatory markers, but the most important study was published in 2019, which is the Colchicine trial, which was also presented in our morning session. The use of colchicine after recent myocardial infarction in a less than 1 month period, involving 4,745 patients, revealed that there is a reduction in cardiovascular endpoints, about a 23% reduction in terms of composite cardiovascular death, cardiovascular cardiac arrest, myocardial infarction, stroke, and urgent hospitalization for angina was significantly reduced. And thereafter, this trial was presented at the American College of Cardiology Annual Congress in December 2019, and it was published as the New England Journal of Medicine that month. And the study was from a team of investigators from Canada. So this was the summary of the Colchicine trial, which showed a significant benefit in terms of cardiovascular outcomes, the use of low-dose colchicine. The combined acute and chronic coronary syndromes, the use of colchicine in major studies of the Colchicine, COPS, and the low-do CO2 trial. This is published as the European Heart Journal last February in 2021. The meta-analysis revealed favors for the use of colchicine in chronic as well as acute coronary syndrome. So the other applicability is colchicine for the prevention of atrial fibrillation. This is an emerging field of study that atrial fibrillation is the most common complication after cardiac surgery, because there is a manipulation of the atria that created a scar and recurrent circuit, and patients after cardiac surgery developed atrial fibrillation. That is a common problem. And there was previous data that post-pericardiotomy syndrome was prevented by the use of colchicine, and that was extrapolated into the use of preventing atrial fibrillation after cardiac surgery, as well as a recurrence of atrial fibrillation after pulmonary vein isolation. Pulmonary vein isolation and ablation is one therapy of atrial fibrillation, but there is a high risk of recurrence because there is a formation of scar there. So that is prevented by use of colchicine. That was demonstrated by the COPS POF. This is the extension of the COPS trial, which is conducted by Massimo Imazio from Italy, which is a double-blinded placebo-controlled trial. Though the patient number is low, 336 patients, revealed that giving colchicine 1 milligram on the third post-operative day, followed by 0.5 milligram daily, revealed a reduction of post-operative atrial fibrillation. As you see from this data, there is a reduction by 12% compared to 22%, by half the recurrence of atrial fibrillation in post-operative atrial fibrillation is reduced. In those patients undergoing pulmonary vein ablation, giving colchicine after ablation for 3 months reduction of post-operative post-procedural atrial fibrillation and a reduction in CRP as well. So these are the studies that I have already mentioned. In general, in 2016, there is a meta-analysis published as the Journal of the American College of Cardiology Clinical Electrophysiology journal, demonstrating that colchicine for prevention of post-operative atrial fibrillation, and in all the studies, it favors colchicine, as you see in this meta-analysis frozen float chart. So the overall risk for GI intolerance is high as compared to placebo. Placebo is favored. It has a GI side effect, but in terms of discontinuation, overall risk of early treatment discontinuation is not significant. It's not significant, so the p-value is less than 0.05. So colchicine is safe and a tolerable drug.
Dr. Desalew, sorry, what was the dose used? Sorry, because diarrhea is one of the major side effects. The dose used.
Low dose, low dose. The doses are low.
Okay.
Low dose, I will give that emphasis later. So that is one of the use in as a laxative in ancient Greek times. Its side effect diarrhea as a laxative, but the GI side effects are dose dependent, and the applicability of colchicine is preferred with lower doses. If patients are less than 70 kg, doses should be 0.5 milligram per day. But if the weight of the patient is more than 70 kg, 0.5 milligram on BID basis. But for prevention of post-operative atrial fibrillation and pericardiotomy, for 3 days and so on, or as a loading dose, 1 milligram can be given, but more than 1 milligram is intolerant. So colchicine in patients with heart failure, the involvement of anti-inflammatory pathways in the pro-fibrotic process associated with adverse ventricular remodeling, especially after post-myocardial infarction heart failure. And that was, the idea was inserted, and a study was conducted to demonstrate an evidence to be used in heart failure with reduced left ventricular function. But there is, it's a negative result, of course, but there is a clinical improvement. This is the study, the anti-inflammatory treatment with colchicine in stable coronary chronic heart failure with reduced left ventricular function, which is a prospective randomized study which was published in the JACC Heart Failure in 2014. Despite a significant reduction in high sensitivity C-reactive protein, as you see in the graph, and also a reduction in interleukin-6, significant reduction, but the improvement in primary endpoints, improvement in NIA class, as well as improvement in left ventricular function and left ventricular dimensions is not significant. But still, there is a clinical significance between 11% and 14%. And researchers are now conducting ongoing trials. There are 2 very important ongoing trials that we are expecting results, positive results. That is, colchicine was low-dose colchicine was tried in post-MI heart failure in regressing ventricular remodeling. The covert MI trial, it is ongoing, and the clear synergy study, it's a registered ongoing study. We will expect positive results. Yesterday night, I was trying to look the clinicaltrials.gov website for heart failure and colchicine. There are additional 3 studies in the pipeline, even in for use in heart failure with preserved ejection fraction, in those patients having acutely decompensated heart failure, and in patients to prevent sympathetic denervation after acute myocardial infarction. Some are recruiting and some are under development, and we will hear the results in the future come. So colchicine use as a regulatory approval. For over a century, treatment and prevention of acute gout was the most common clinical approved indication for short and long-term use of colchicine. Over 50 years ago, the safety and effectiveness of continuous lifelong colchicine for the prevention of acute inflammatory flares in patients with familial Mediterranean fever led to its regulatory approval. For this purpose, it is already approved. Long-term colchicine has also been used off-label for the treatment of Behçet's syndrome and pseudo-gout. Colchicine was also introduced in the field of cardiology for the treatment and prevention of recurrent pericarditis, acute pericarditis, and it was incorporated in the guidelines since 2015, and it is in use in the globe, in the medical community. Regarding Ethiopia, it is included in the Ethiopian Essential. It's not only in the medical list, but it is also included in the Ethiopian Essential Medicines list of the 6th edition, September 2020, the most recent one, as a medicine used for gout. It's registered as a tablet, 0.5 milligram, and it's available in local pharmacy, both public and private. But there are complaints that we are hearing that the drug is expiring. Doctors are not ordering this molecule for the treatment of diseases. What is new beyond cardiology? I was searching articles, and because of its anti-inflammatory effect, especially its anti-interleukin 6 effect, can it be used for corona? COVID is a big issue, and there is one publication from the Lancet Respiratory, which was published online May 27, 2017, showing a positive signal, a light at the end of the tunnel to be applied for the management of COVID-19. Previously, there were trials in the recovery. They tried colchicine, which was not published. And there was a very small study, negative study, the Greco-19 trial involving 105 patients. And there is also an ongoing trial, colchicine, in moderate symptomatic COVID-19 patients called COVID-BD, which is an ongoing trial. But this one is a new one involving around 4,488 patients randomized and done in highly COVID-affected countries like Brazil, Spain, United States, Canada, South Africa, where was involved in this study. And in those patients having a positive result, PCR positive confirmed COVID-19 patients can be used, given the absence of orally administered therapies to prevent COVID-19 complications in community-treated patients and the benefit of colchicine in patients with PCR positive COVID-19. This safe and inexpensive anti-inflammatory agent could be considered for use in those at-risk complications. I think this type of studies can be also replicated in our country as well. So in conclusion, colchicine is a sophisticated anti-inflammatory agent that has been used for centuries for the treatment and prevention of gout, and for over 50 years for the prevention of acute inflammatory flares in patients with familiar Mediterranean fever. Almost 35 years ago, the observed benefit of colchicine in the prevention and treatment of polyserositis in patients with familial Mediterranean fever led to its introduction into cardiovascular medicine for the treatment and prevention of pericarditis. Subsequent randomized trials confirming its safety and efficacy have resulted in it being adopted in the guidelines as a first-line therapy for this indication, as we have already discussed. And over the last 15 years, it is incorporated as there are clinical trials are coming for its use in chronic, in coronary artery disease, post-MI, as well as in chronic coronary syndrome patients for its effect for anti-inflammatory effect, not on top of a standard therapy, on top of other antiplatelet therapies, as well as on top of lipid-lowering therapies. And over the next 3 to 5 years, ongoing trials will add information about the benefits of colchicine in cardiovascular disease, including post-procedural atrial fibrillation prevention, as well as heart failure treatment. We will be hearing good news as we go along. With this, I will end my talk. Thank you very much. If you have questions, comments, or suggestions, you are welcome.
Thank you so much, Doctor. So we'll proceed to the post test. So everyone who have question can ask in the meantime.
Can I say a few words?
Yes, yes, Doctor. Proceed.
It's a very nice presentation. I would say it's kind of a state of art. You know, you reviewed the most up-to-date literature, so it was really exciting. So again, my question is around the diarrhea issue. You know, in the few cases whom I know, diarrhea is one of the most, limiting risk factors, adverse events. So what's the dose in relation to where, the diarrhea would be really an issue, Dr. Desalew? All the studies, particularly the COVID, is, NI said insufficient evidences to recommend. So I don't think at this point in time we can recommend colchicine. It said insufficient evidences. Thank you, Dr. Desalew.
Yeah, thank you very much. Regarding diarrhea, the GI side effects are one of the limiting factors for the wider use of colchicine. And it was, by the way, the drug was banned for more than 500 years by British scientists before because of its diarrhea, and it's also grown in meadow areas, in livestock areas, resulting in livestock poisoning, causing diarrhea, and that is dose dependent. That's dose dependent. That is why low doses are recommended. So the recommendation is low dose, and the diarrhea effect is dose dependent because the absorption is more in the jejunum and ileum. It interferes with the absorption, so it is more of dose dependent. And that was also the most reported side effect of colchicine is a gastrointestinal issues. Otherwise, it is a safe and tolerable drug in low doses, and in clinical trials, the rate of discontinuation was very low. It is clearly summarized regarding COVID. NIH recommended in April 21, 2021. There is no insufficient data. Even the Call Corona, which is published in May 27, the one that I displayed, is just a study, one randomized control trial, and there is not yet recommended, but still such similar clinical trials, I think, can be conducted. This is also very good for our researchers in the field to conduct similar studies in the field.
What does the sign, what does the hand sign next to the colchicine molecule indicate?
The heart. It's the repurposing of colchicine from treating pain and symptoms into cardiovascular prevention and treatment.
Thank you. I thought you want to say I love you.
Yeah, it's a woman hand and sees a nail paints. Yeah.
Okay. Dr. Yondasan, I think you have comment.
Colchicine is really a drug. I've used it only in patients with gout, of course, and a few patients with lupus who have some vasculitis. It was actually suggested by rheumatologists elsewhere. I've used it in a few patients. It's a wonderful drug. The side effects like diarrhea occur when you use it in acute gout, several doses, one after the other until the resolution of symptoms. It's not a common side effect in the doses Dr. Desalew mentioned, 0.5 to 1 milligram a day. As I indicated in the chat box, it's never been regularly available in the Ethiopian market, never. The only time I remember it was available was a few years ago when we had some stock into Korambessa, but the importers, including the government importer, never bothered to import colchicine. So we must make efforts to make it as regularly available, particularly for patients with gout, who have CKD and so on, when it becomes the only choice in the management of patients with CKD and gout, autophagious gout, and so on and so forth. When you have to use allopurinol on long term. It's interesting to hear about the additional benefits of colchicine in areas other than the traditional indications. If I remember correctly, there was a discussion of the use of colchicine in liver fibrosis some time ago. So it's very likely that we're going to hear more and more about colchicine in the months and years to come. Thank you.
Thank you, Dr. Rondi. It was a nice supplement. But some pharmacies are complaining, especially the Emmanuel Hospital public pharmacy. I heard complaining about expiry of the drug because doctors are not prescribing. And some, there was also a complaint. It was available in our pharmacy and it was not prescribed. I think we have to work hard to. One of the reasons that drugs can be imported is when it is prescribed. So we have to prescribe, not for the indications that I have mentioned, not for chronic coronary syndrome. It is not incorporated in the guidelines, but at least for gout, pseudo gout, and for autoimmune disorders, and in pericarditis as well, can be prescribed. And when prescriptions are running in here and there, the drug can be available. The other thing is the inception of trials in the field. This is a very cheap drug, and I think we have to think about a sort of clinical trial in one way or another, because it has an anti-interleukin-6 activity, and patients were buying tocilizumab, which is a very expensive drug, costing 120,000 per dose, and people treating COVID-19 might think about that as well. ኮርኳሪ ለማድረግ ነው እንጂ
Okay, thank you. So there is also one comment from Dr. Brahanu. Please. Can you see the chat box, Doctor, or shall I read it?
Okay, let me see the. Okay, I didn't see it. Okay. Can you read it?
Yeah. So regarding the prescription from our side, the price is 900 birr of PID dose for a month. So do we know a price? Is the question.
Yeah. I don't know the exact, the currently available price, but it's much, it's affordable, I think, by the community. It's relatively better as comparable to other anti-inflammatory drugs.
Okay, thank you, doctor. So can you see the results of the post-test, doctor?
Yeah. Where is the post-test?
Can't you see the result? I have shared it.
Share it again. I didn't.
Can you see it now?
Okay, yes, yes. I see, yeah. The first line treatment for choice in acute pericarditis, yes, it is NSAID. After NSAID and NSAID, followed by, should be, colchicine can be added on top of that. Majority respond to that. Steroids as a first line is not recommended. Yes, most common side effect for discontinuation is GI symptoms, as also supplemented by Dr. Wonderson. For preventive therapy, secondary prevention, its anti-inflammatory effect is needed. And unanimously, everybody agreed that the cardiovascular benefit of colchicine in the trial is best observed at low dose. Thank you very much. And it is available in the Ethiopian essential medicines list. But as Dr. Yondosan clearly mentioned, it's not widely available and there are interruptions. Thank you. So the update lecture targets its aim. It looks it is attended. Thank you very much.
Yeah, thank you so much, doctor. So we will wind up our morning session here. Have a good day, everyone.
Have a good day. Thank you.